Now that the formalities are out of the way, we are inviting you to sit back, relax, and enjoy our keynote speaker. We couldn't be more thrilled to welcome Dr. Athena Poppas. She's the Chief of Cardiology at Lifespan Cardiovascular Institute in Rhode Island and Professor of Medicine at Brown University. She's the immediate past president of the American College of Cardiology and helped to lead the strategic plan implementation during a time of continuous improvement, innovation, and change in the field of cardiovascular medicine. Not only that, she braved blizzards, ice storms, and Omicron to be here today to give our keynote address. We're thrilled to welcome Dr. Athena Poppas.
Well, thank you very much. That's a really kind introduction, and I'm thrilled to be here, not just because of the ice storm back home. And I wanted to give a big shout out to Dr. LaJoy, Dr. Weinberg, and Dr. Vanderzee. What an amazing program you put on. It is very hard to do this where you're mixing in person and virtual. Again, not easy to do. Others have stumbled, but you guys have clearly succeeded. So congratulations, a lot of good work. So. I'm going to hopefully spend, I thought given the topic that we're talking about, to try to focus a little bit on heart disease in women, and hope that we can have some conversation at the end as well. I don't have any disclosures that are pertinent to the talk at hand. I thought I'd begin with the way that most of us spend our day, and that is talking about a patient of mine. She was a young woman, young because she's younger than me, who presented with ACS. She had a past medical history that seemed unremarkable. Her social history is noted there, her family history, an exam, and laboratory values. And here was her catheterization, and you can see she had significant tight disease. And her question to me was, why me? How did this happen? So hopefully by the end of the next 30 to 40 minutes, we'll have some answers, but I think everyone may have some answers. This is just an outline of some of the things I'd like to cover, looking at some of the emerging trends in cardiovascular disease in general and women in particular. What does our guidelines and really honestly just guidance say to us today, and how do we look at risk assessment? What are some of the differences in risk factors between men and women, both traditional and those that just are more prominent in women? And what are some unique factors in women, or better defined recently as risk enhancers? And then lastly, let's end with the future and what are we going to do about implementation. No surprise there, cardiovascular mortality varies by region. Around the globe, green being better, red being worse. Not meant to be a political statement here. Heart disease also varies within the US, and you can look around the country, you can look around the zip code as we're aware. So a lot of variation in cardiovascular disease and mortality. So a lot of work for us to continue to do. So the question is why? Why does cardiovascular disease rate vary both by gender and race? If you look at, for example, women have a higher population-adjusted cardiovascular mortality compared to men. And then from the recent AHA stroke statistics, women have a higher mortality 1 year after their first MI in this younger age group. Difference between white men and white women, and equally, if not more concerning, a significant difference, white men versus black men, and difference between white women and black women. Similar sort of pattern when we look at mortality at 5 years in the younger age group, the difference between men and women and between race. Look at the mortality for black females compared to white males. Similar trends when we look at, again, older age group with a higher mortality. So why? We've made progress, and that's the good news. We've seen by age group a decline over the last 20 to 30 years, by dual eligible, so whether you're insured or not insured, by sex and by race. But this is seemingly a complex slide, and Dr. Mertz, I understand, is part of your practice, and this is the other Dr. Mertz. And so her work has worked at this, and I think this really is helpful for me to understand. So looking at rate of first MI by sex compared to odds ratio in men versus women for mortality. So though the rate is lower for first MI in women compared to men, the rate of mortality is twofold higher in younger women compared to older women and men. So what does that mean? That means that women may have less MIs at a younger age, but their mortality is twofold higher than men. Similar thing noted, looking at the trends. Again, trends over years. I showed you that earlier. 79 is a long time ago. But in this younger age group, under 55, an alarming trend. If we zoom in here, this is women down here and men up here, and a pretty flat trend, no change. Why? So it's varying by age, it's varying by race, it's varying by sex. There's biologic factors, there's no one answer, we'd have fixed it by now. There's differential effects of risk factors, there's difference in social and economic supports, and there is some systemic racism and sexism that may affect this. This is a different way of looking at it from the strokes AHA statistics. It's age-adjusted prevalence of risk factors, or risk health. So the converse of a risk factor, but health. And you can see that, again, the risk factors that underpin some of that mortality and morbidity, difference by non-Hispanic white, non-Hispanic black, blue being good. And you can see difference in smoking, body mass index, physical activity, et cetera. The point is, one, we're not doing very well with things such as healthy diet. Where's my healthy diet friends? But it definitely varies by gender, and it varies by race. What about the impact of social determinants of health? I don't know why we hadn't thought about this or talked about this much, but we do have plenty of data to know that about 20% of a person's health and well-being is related to access to care and the quality of services. And we in this room, most of us spend a huge amount of our time really thinking we're going to change things in a person, but we're really just talking about 20%. There's this entire rest of the iceberg, and that is the physical environment, the social determinants, and behavioral factors that affect a person's health. So we're starting to understand, perhaps, why there's some difference both in race and gender. But it's not all grim. A great paper looking at the quality and equitable healthcare gaps. So quality and equitable healthcare gaps for women. And its difference in medicine. And this is looking at the social determinants of health, defined here. These are some Kaiser groupings. And importantly, socioeconomic disadvantage significantly has a greater influence in women and may have a greater influence in race. So the intersection, race is really not a biologic variable, it really is a social variable. And so what we're seeing is we need to really think about these other pieces and work with our partners, our other team members who are affecting these other components of health. Again, not grim. Here's the problem. Here's some solutions. So Leslie Shaw, who's worked a lot on this, look, how do we achieve then health equity for care? So here's the delta. Here's the avoidable morbidity and mortality when we look at a diverse group of women. Patient-centeredness, here's some solutions. Community partnerships, as you're doing here. Reducing barriers to care. Unique population management, innovative research, and then looking at health system and redesign and reform. This is just one tool which is worth thinking about to implement in practice. You can download it from a website, but we do lots of standardized tools, paper, hopefully electronic when people come in to see us. But how can we do some screening for health-related social needs? Now, primary care is starting to absorb this in their practice, but it's something for us to think about with our cardiovascular patients as well. And it's a way to just get in a quick snapshot what might be some of the barriers. Are they a non-compliant patient, or do they have access issues and financial issues? So we talked about emerging trends. What are some of the problems? What might be some of the solutions in the difference between both race and gender? What do some of our guidelines or guidance say about risk assessment for our patients? Over 10 years ago, AHA wrote a nice effectiveness-based guideline for the prevention of cardiovascular disease in women. And for the first time started to change the conversation and look at a little bit broader look of risk factors, those that are at high risk, those that are at risk, and those that are in ideal risk. And one thing that started to emerge from this conversation and this paper was there's some really unique risk factors in women: central adiposity, autoimmune disorders, and pregnancy complications that really had not been part of the conversation, and we started to look at these things and ask those questions. So what about our guidelines? The ACC-HA guidelines, the recent ones on management of blood cholesterol, for the first time there's a few areas where went the wrong way, where we look specifically, and when we're talking about treatment, here's something where we're looking at premature menopause, history of pregnancy-associated disorders, when we're talking about lifestyle and statin therapy. So for the first time, there's some components that are specific for gender. What about the guidelines and prevention in general? Again, for the first time, we're seeing risk-enhancing factors, so some of these more unique factors coming out, and looking at a history of premature menopause. We're going to talk a little bit more about all of this, and high-risk race and ethnicity, such as South Asian ancestry. So again, pulling out some of these things specific to the guidelines for the first time. We need to have more of that, but at least we're talking about it. This is a really great summary, thinking about cardiovascular disease and risk factors in women, trying to bracket them and how do we think about them all together. So the traditional risk factors we learned long ago in med school and nursing school. There's a number of other factors that you're seeing in some of these risk-enhancing factors and hormonal factors. Social determinants of health we were just talking about that impact that. Psychologic risk factors. What might be a common pathway is inflammation, leading to endothelial and subclinical dysfunction, and ultimately cardiovascular disease. But a way to sort of frame the conversation and look at perhaps causality. There wasn't a lot about guidelines and guidance because there isn't a lot, but this is what we have, and now we have more data that we're going to walk through about. Let's dive in a little bit about those risk factors, what we do and don't know, and what we may need to do in the future. Well, these are the typical risk factors. And I'm highlighting those that may be unique or more prominent in women. So tobacco. Unfortunately, the decline in smoking has been slower in women and those of lower socioeconomic or education. We know that for middle-aged and younger women, up to half of myocardial infarctions are due to smoking. And it's a greater risk, 25% greater in women compared to men. And that's from a meta-analysis that was done. This is just one small study, but it really highlights the importance and the differential importance of smoking in women. I believe this was a Finnish group, but what you can see is here's age of first heart attack. Non-smoking, for women, it was 79 years old. For smokers, it was 60. That's a pretty big delta. For men, there is a difference, but the difference is not as great. You can see there's also a fair amount of overlap. So again, smoking has a differential effect and a greater effect in women compared to men. Unfortunately, industry is not helping us. They continue to advertise aggressively, particularly for younger women and girls. And though there was a decline in smoking, particularly in this younger age group, we still see smoking and vaping with a marked increase in e-cigarettes among women and girls. So work to do. Switching to other typical risk factors, what about hypertension? Hypertension, this looks at Nanette Wenger's work, among many other great things she's done. Deaths attributable to risks. So high blood pressure, significant cardiovascular risk factor. And what about the differential prevalence of hypertension, looking at everybody, men and women by age group, men in particular and women. And then as we start to get over 60, hypertension is a bigger risk factor in women. So as women age, we're seeing more hypertension. Equally concerning is the not only the prevalence, but the control that varies both by sex and race. So this is the total, this is men, and this is by race, and that you can see there's a difference in men that have controlled hypertension, and for women, the percentage of those that have their hypertension controlled. So again, a difference in gender and a difference in race. So work for us to do. And when we talk about control of hypertension, let's not forget the non-pharmacologic interventions. We know that weight contributes to hypertension, and we also know the converse, that just 5 to 10% of weight loss can lower blood pressure. Same with diet being related to hypertension. A lot of interesting work. I think one of the upcoming late-breaking trials at the ACC is going to be on diet, which is unusual. So again, DASH diet, well known to reduce blood pressure, and physical inactivity increasing risk, but activity reducing risk. So if this was a blockbuster pill, we'd certainly be selling it, and I love to tell my patients that. What about cholesterol? Well, there's a lot of interesting recent data, and it's really not so simple. So when you peel that onion back, we've known for a long time that for women, there's an increased risk with elevated triglycerides and with lower HDL. And that as HDL increases, it decreases cardiovascular risk, and that's a more prominent finding in women compared to men. We also know that aggressively lowering LDL reduces events and deaths. And in secondary prevention from the clinical trialist work and meta-analysis, there was not heterogeneity by gender. Remember years ago, there was some debate about that. Here's a really interesting recent study that looked at women through the menopause transition. So does menopause cause cardiovascular disease? It seemed to increase. Well, this was a really well done study. And what you can see is premenopause, menopause transition, and postmenopause, the change in HDL subclass, there's a change in concentration of HDL subclass and lipid content, and that there's a change in the efflux capacity. So what we're seeing is it's not so simple. So there's really a change not only in the particle, but also in the effectiveness of removing it. And so the atherogenic lipoproteins is a certainly complex story. So we know that in postmenopausal women, they have more small HDL. And the large HDL gets converted to these smaller particles by an increase in hepatic lipase activity. Estrogen inhibits hepatic lipase activity. So you can start to see how these start to affect each other. And in menopause, the association between HDL and cardiovascular disease may switch from being protective to actually potentially being harmful. And this is not only from the SWAN study, but also MESA and the Los Angeles trial, which was recent, where they saw an increase in HDL associated with an increase in IMT in postmenopausal women and an increased risk of stroke. So the cholesterol particles themselves may be changing and the risk may change. We'll come back to that in a little bit. What about diabetes in women? A similar story, a more powerful risk predictor in women. And we know that globally the risk of diabetes is increasing and that half is preventable again. Women have a 50% excess relative risk of cardiovascular disease with diabetes compared to men. And this is from Salim Yusuf's work. Also, importantly, and this is not that old a data, even though most of the mortality in diabetics is due to cardiovascular disease, the vast majority do not consider cardiovascular disease even as a possible complication. So a lot of work for us to do in education. This is an older slide, but I like it because it shows sort of the grim story of the epidemic of not only obesity, but diabetes, geographic variation, which we might overlay on that, both morbidity, mortality. But here we see the obesity increase over this period of time, and it mirrors the increase in diabetes. So we're coming back to that classification from Lori Mosco's work, obesity, particularly central obesity for women, and metabolic syndrome being a particular risk factor for women. Obesity contributes to and compounds other risk factors, and that's a really important take-home point. It's not just the obesity, but they seem to work together on central obesity. Less activity, higher lipids, more obesity, more insulin resistance. And we know that for every increase in BMI, you get a significant increase in risk. And it's more significant in women compared to men. Metabolic syndrome is really this intersection of both obesity, lipids, glucose, and blood pressure. And this is where this intersection and I would say negative cycle happens. There's greater loss of physical functioning. It contributes to greater weight gain, insulin resistance, and hypertension. And getting off that cycle becomes incredibly important. This is just one study that looked at diabetes, metabolic syndrome, and neither in women in particular. And you can see that freedom from death and freedom from MACE over 4 years, difference between normal, those with metabolic syndrome and diabetes. So though we think it's a risk factor, it has a very significant impact, immediate or medium between normal and diabetic patients. So we talked about the traditional risk factors. What are some of the non-traditional risk factors that have unique features, particularly in women? Again, this is from Salim Yusuf's work, which was international and has a rich group of diverse patients. And here is attributable risks for first myocardial infarction. So these are 9 different risk factors. If you have all 9, it's 90% personal attributable risk. And if we look at psychosocial, 33% But digging in a little bit, it's 45% for women and 29% for men. So a differential effect of the psychosocial effect on cardiovascular risk. A few studies, and there's a number that we could talk about, particularly among women. This is from the Nurses' Health Study, where women with no history of cardiovascular disease, depression alone was an independent predictor of death and of cardiovascular death. For women with established coronary disease, marital stress, but not work stress, probably could have a whole conversation about that, was associated with a threefold increased risk of recurrent cardiovascular events. No judgment there, just stating the facts. What about autoimmune disorders? We know that women tend to have more autoimmune disorders. So rheumatoid arthritis, lupus, for example, or antiphospholipid antibody, they're associated with an increased risk of cardiovascular disease. Twofold increased risk in rheumatoid and with lupus. But in younger women that have lupus in particular, it can be an eightfold risk. So we may be missing an opportunity in these high-risk women. Inflammation appears to be the common pathway. And for example, the risk correlates with disease flares and SED rate. So you can see there's perhaps this common pathway. It's not clear that intervening makes a difference, but awareness alone. We also know that lupus has 8-to-1 incidence in women compared to men. So it is now considered risk enhancing, and we should consider primary prevention in those women in particular. And this is what our guidelines speak to. We mentioned metabolic syndrome earlier, but here we have chronic inflammatory conditions being culled out, in particular psoriasis, lupus, and RA. So I'm going to get some water. HIV and AIDS as well. So again, some inflammatory conditions that we should pay attention to. So we talked about some of the unique factors, but what are things that are female-specific risk factors and are now defined as risk-enhancing? I starred the two that have enough data that they've actually been pulled into the guidelines. The others are interesting, and we'll talk about those. A recent statement from the AHA with I think ACOG, looking at the menopausal transition and cardiovascular disease, and looking at the timing of risk prevention. Not saying it's a cause, but it's an opportunity. Just like pregnancy is an opportunity to reach women during a very important point to talk about cardiovascular risk. So people have started to talk about the reproductive lifespan and risk. So the shorter the reproductive lifespan, the greater the risk. What does that mean? Well, early menarche has an inconsistent sort of U-shaped curve, probably confounded by obesity. Early menarche is often in heavier young girls or diabetes. On the other hand, early menopause consistently found to have increased risk. And this is defined as loss of ovarian activity before age 40. So really, premature menopause is very specific. Though rare, about 1% of women. It is associated with increased cardiovascular risk and all-cause mortality. We're going to come back to that because that's interesting. So women's risk of cardiovascular disease, it increases after the menopause. We've all known that. The question is it age or is it hormone related? And we'll dig into this. So early menopause, whether surgical or natural, is associated with increased cardiovascular risk and all-cause mortality. Cause and effect. Does not prove causality. But that risk is bidirectional. That's really interesting. So early menopause is a marker of both reproductive and general health and somatic aging. So women with risk factors have early menopause. So it's this bidirectional thing we hadn't really thought about and nobody had delved into to sort of tease that apart. And some of this work comes from looking at genetic variants, and there's genetic pleiotropy in here. So particular variants are associated with both early menopause and cardiac risk factors. And some epigenetic studies have suggested that there's co-inheritability. So both for the age of menopause and age acceleration. So both somatic and reproductive aging, if you will. So cause, consequence, or both? Not so simple. So cardiac risk factors account for and may cause early menopause. From the Framing on Heart study, for example, higher triglycerides, higher blood pressure, and weight were associated with an early age of menopause transition. Increase in risk factors is associated with premature menopause and some CHIP-associated genetic variants in premature menopause and coronary disease. So the same abnormality was associated with both those things. That's that genetic pleiotropy from some really interesting work from Hornberger at, I think it's at MGH. So premature menopause is associated with accelerated aging. It's been defined as this epigenetic clock, so looking at DNA methylation, and again, this co-inheritability of those two things. So it's increased in those that have bilateral salpingo-oophorectomies, and it's decreased in those with hormone replacement therapy afterwards. So pretty interesting work there. So to sum, age-related changes should be linear. And so it looks like hypertension, insulin, blood sugar, and weight changes in a linear fashion for men and women. On the other hand, menopause-related changes should be a sharp inflection at the time of the menopause transition. And what a number of studies have shown is that's true for particular lipids, triglycerides, LDL, and that HDL change in particle distribution that I mentioned in that prior study. Also metabolic syndrome with a central adiposity and more pronounced in women of color. So to come back to the SWAN study, this is the one that really looked at in a diverse population, over 3,000 followed, and you can see the inflection point versus just a linear change. So the linear change in insulin, but epidemiologic studies in the past didn't have this level of detail because they didn't have concurrent measures of covariates, and we just thought, oh, it's changing at menopause. But this is really an elegant study that I think separates out what's happening that's age-related versus gender-related. So again, another important work looking at how we can work together with gynecologists and obstetricians, so collaborating and look at cardiovascular risk of women throughout their reproductive lifespan. So let's switch then from what's unique in women from around the menopause to what's unique in women that around pregnancy outcomes. So we know that adverse pregnancy outcomes are unfortunately common. They're increasing in frequency, and they're more common in African American women. So 10 to 20% of women in the States have adverse outcomes. It increases the risk of future cardiovascular events by 2 to 4-fold, so an opportunity. And ACOG currently recommends risk factor screening at 3 months postpartum. So we've been trying to do that where we work together and have a postpartum risk assessment where we work with our MFM colleagues. It's small enough in Rhode Island we can do that. And the etiology appears, this is, we probably haven't thought about this for a long time, but that's the placenta. And so it appears to be both placental and endothelial dysfunction may be the common pathway linking these things. So adverse pregnancy outcomes appear to be due to vascular remodeling. So this is normal placentation, this is abnormal placentation. And you can see that, just to review some of that, but it's to reduce the hypertension that may exist within the placenta so that there's free flow. So it's abnormal vascular remodeling. So between these two, there's shared vascular factors. Preeclampsia cardiovascular disease, endothelial dysfunction, vasomotor dysfunction, and some specific pathologic lesions. There's shared metabolic factors, insulin resistance. All of these are risk factors for both diseases. And lastly, shared specific risk factors of hypertension, obesity, and diabetes, and as I mentioned, Black race. So where are these overlaps? Let's delve in a little bit more. We know that the complication of pregnancy increases the risk for cardiovascular disease. So preeclampsia alone, unfortunately, occurs in 6 to 8% of pregnancies. It carries a 4-fold higher risk of hypertension in the future and a 2-fold higher risk of coronary disease and stroke. It's up to us, and I think working with our obstetricians to educate women. Stillbirth increases the risk, and miscarriage increases the risk. That's a little more complex. Here's just one example of maternal survival after preeclampsia. Here's hazard ratio for death in cardiovascular disease, long time, 25 years, but it's 8-fold. And when we look at those with preeclampsia and preterm delivery. This is one study, but it was a Finnish cohort of over 10,000 women followed for over 40 years where they were able to adjust for a number of confounding risks because they had collected those. And they saw an increased risk of ischemic heart disease, MI, heart failure, and stroke with a hazard ratio of these anywhere from 1.4 to 3-fold. This is that study, graphic representation. It's 1 minus survival, so it's a little bit confusing, but you can see there's a differentiation whether we're looking at myocardial infarction death, myocardial infarctions, or any cardiovascular disease, from those that are normotensive those up to, in a graded fashion, those with superimposed preeclampsia or eclampsia. So again, it does affect survival and it does affect cardiovascular disease. This is a meta-analysis, and you can see the forest plot from a number of studies that looked at ischemic heart disease and the relative risk, decreased risk versus increased risk of preeclampsia, and pretty consistently about a twofold increased risk. So that's where that number comes from, a number of small studies that put that together. An interesting study showing the additive effects of adverse pregnancy outcomes, here defined as MPS, I think is maternal placental syndromes is the language they used. So CHAMPS was done up in Canada, and they looked at disease and then cardiovascular risk factors on top of that disease. So we said that they may be cause, but the more that you have, the higher the future risk. So if you just have maternal adverse pregnancy outcome, but if you also have pre-pregnancy hypertension, and that, it increases your risk for future events significantly. Same for obesity. If you have obesity and adverse pregnancy outcome, it increases your risk. Dyslipidemia, metabolic syndrome. If you have a number of these, tobacco use. So again, what we're seeing here is that having an adverse pregnancy outcome is increased risk. The more other risk factors you have, the greater the future risk of events. So I think a very elegant study to take that apart. So it seems sort of grim, but why is this happening? And just to come back around. So there seems to be risk factor clusters, perhaps around placental and vascular abnormalities, leading to adverse pregnancy outcomes, whether it's cardiac mechanics, endothelial dysfunction, and compliance, and overt disease. Sedentary behavior and inflammation may be part of this as well. So what can we do to sort of think a little bit differently? We can think about pregnancy or cardiovascular disease in the context of a woman's health across the lifespan. So a number of us sort of intersect at different parts, but cardiology and cardiologists can intersect across the entire lifespan that a woman, from working with pediatricians, obstetricians, and internists, and people have talked about preconception care, prenatal care, and interconception, either to the next pregnancy or afterwards. So again, thinking a little differently about the care of women. So let's come back to where we started. The young patient of mine who said, why me? Well, she was G2P2. I didn't ask, but she'd had preeclampsia. She was taking vitamin E, which is a class 3 recommendation, not beneficial. She was recently divorced, so she had a lot of psychosocial stress. She had been a smoker. Her father, she had family history, it matters in women. She was overweight and obese. She had new hypertension, and she had a low HDL. So the real question is, why did we not prevent this? So I hope that I've left you with a way forward for this young woman and a future direction and implementation. First problem we talked about is static mortality trends. So awareness and primary prevention will be important. We need research focus on sex-based mechanisms and inclusive of diverse women. We need to look at both health equity and social determinants of health and how those intersect with some of the static mortality trends. We probably need living guidelines, and we're working on this, where the next iteration in a year will have guidelines that can be updated electronically every year. And we need to be more thoughtful and inclusive of these risk enhancers. Research has to shift from observational to implementation, and then looking at these unique risk factors in women and really collaborating with our primary care and OBGYN colleagues, and looking at some research focused on the intersection of vascular factors and reproductive versus chronologic somatic aging, I think is an interesting area that we're going to hear more about. So with that, these are our fellows. It was this brief period this summer where we got together without masks. This was their graduation, and I thank you for your attention.